Hello everyone, welcome back to Pathology Basics. Today we'll be continuing with chapter number 4, which is hemodynamic disorders. Let us see answers to the questions that I had posted in the last lecture. The first question was, what is the content of alpha granules of platelets? The aim behind posting this question was that you remember the contents of all the granules of the platelets, because this can be asked as a part of multiple choice questions. So you know that platelets play a primary role in hemostasis. Their function depends on several glycoprotein receptors, contractile cytoskeleton, and most importantly, granules. There are two granules, alpha granules and the dense or delta granules. Alpha granules contain proteins involved in coagulation and certain factors that are involved in wound healing. Right, so the proteins involved in coagulation, they include fibrinogen, coagulation factor 5 and von Willebrand factor. Whereas proteins involved in wound healing, they are primarily fibronectin, platelet factor 4, PDGF and a transforming growth factor beta. Delta granules on the other hand, they contain ionized calcium, which you might be knowing or remember that is involved in activation of coagulation pathways. ADP, serotonin, epinephrine, and adenosine triphosphate or ATP are also contents of the dense granules. Next question was, what are the stalling forces? Now you know that when I taught you about mechanisms of edema and effusion, there are two forces that act keeping the fluid or maintaining balance of fluid in the intravascular and the extravascular compartment. They are the hydrostatic pressure, which pushes the fluid out of the blood vessels, and plasma colloid oncotic pressure, which acts in the opposite manner. Now these two, hydrostatic and the plasma colloid oncotic pressure, are what we call as the stalling forces. So now coming to today's topic, today's is the part 2 on lecture on chapter number 4. We'll be covering thrombosis, embolism and shock today. So coming to thrombosis, we'll be covering thrombosis under these headers. First we'll be discussing the Virchow triad or the Virchow triad, morphology of thrombus I'll be covering, clinical features, and finally what is the fate of a thrombus. So let's see Virchow's triad first. The Virchow triad includes three distinct entities. First, in order that a thrombosis happens, there are three things that should happen. Number one, there must be an endothelial injury, because the endothelium is the one which prevents clotting. Hypercoagulability, okay, that is increased tendency to clot, and abnormal blood flow. Alright, so these three things are what we include in the Virchow triad of thrombosis. Let's see endothelial injury first. Now, endothelial dysfunction can happen because of either an intrinsic susceptibility or some environmental factors. So, the risk factors for endothelial injury include diabetes, dyslipidemia, smoking, hypertension, and aging, infection, inflammation, homocysteine, obesity. All these can cause an endothelial dysfunction. Now, endothelial dysfunction can cause atherosclerotic lesion formation and progression and ultimately cardiovascular disease events. So, endothelium is very important to prevent thrombosis, and endothelium dysfunction can lead to thrombosis. Second factor in the Virchow triad was alterations in the normal blood flow. So, first, it's important to note that the normal blood flow is laminar. What does laminar blood flow mean? Laminar blood flow means different components of the blood flow at different levels. The cells, primarily the WBCs, RBCs, and the platelets, they flow through the center of the blood vessel. This kind of flow is what we call as the laminar flow. Any abnormality with this laminar flow is what we call as stasis or turbulence. What does stasis and turbulence do? It promotes endothelial activation. So the endothelial cells become activated. It disrupts the laminar flow, as a result of which the platelets, instead of flowing through the center of the blood vessel, they come along the endothelium, they come in contact with the endothelium. Also, after the clotting has happened, This disruption in laminar blood flow, it prevents washout and dilution of the activated clotting factors. As a result, it leads to an increased thrombotic tendency, right? So when the blood flow is not laminar, it will cause increased thrombosis, and even after the process or the requirement of the clot is over, still the washout and dilution of clotting factors will be prevented by this stasis or turbulence. Third factor in Virchow's triad was hypercoagulability. So hypercoagulable state can be various. It's primarily genetic, and the most common cause is homocystinuria. This is an emerging concept that increased homocysteine in blood can lead to thrombosis. Acquired hypercoagulable states we know are few. Let's see. Prolonged bed rest or immobilization. We know when the person is immobilized, there is increased tendency for thrombosis in his leg veins. That is called deep vein thrombosis. Prosthetic cardiac valves, they can cause increased thrombosis on the valves itself. I'll be teaching you two syndromes, heparin induced thrombocytopenia syndrome and antiphospholipid antibody syndrome. In both these syndromes, there is increased thrombotic tendency. So let's see these two syndromes first. So let's see this heparin induced thrombocytopenia syndrome, or what we call as a HIT syndrome. This HIT syndrome happens following administration of unfractionated heparin. Now, unfractionated heparin is a type of heparin that was used earlier. Now, what happens is when we give heparin over a period of time, there are antibodies which develop against this unfractionated heparin. These antibodies in turn also bind to platelets and cause activation of the platelets. Hence, there is activation, aggregation, and consumption of platelets. So, platelets are consumed. As a result, there is thrombocytopenia syndrome, right? There is thrombocytopenia. Now, what happens? This effect on platelets, and there is endothelial damage as well. Now, activation of platelets and endothelial damage, it combines to produce a prothrombotic state. Alright, so why do we give heparin? We give heparin so that thrombosis is prevented. But here what happens? There are antibodies against heparin. These antibodies act against platelets as well as damage the endothelium, and instead of preventing thrombosis, it leads to a prothrombotic state. This syndrome is what we call as heparin-induced thrombocytopenia syndrome. Another thing to remember, though there is thrombocytopenia, there is increased thrombosis. What can be done to prevent this? Newer forms of heparin now are available. The best example is a low molecular weight heparin or LMW heparin. Less antibodies, or there are lesser chances of production of autoantibodies against this low molecular weight heparin. As a result, its syndrome is prevented by this. So let's come to antiphospholipid antibody syndrome. This syndrome was discovered when it gave a false positive reaction, or rather the antiphospholipid antibodies gave a false positive reaction for syphilis. Now in syphilis testing, what we do is we do a test called BDRL test, where we add cardiolipin antigen to the patient's serum. So the patient's serum contained antibodies against syphilis, or rather against cardiolipin antigen. In this syndrome, there are antiphospholipid antibodies which act against the cardiolipin antigen used for testing syphilis, and therefore they give a false positive reaction. What are the clinical manifestations of this syndrome? This syndrome was previously called the lupus anticoagulant syndrome also. It has many manifestations, protein manifestations like thrombosis, there are recurrent thrombosis, there is recurrent miscarriage, so much vegetation on the cardiac valves, the platelets are used up, it leads to thrombocytopenia, so it's a very hypercoagulable state. Right? In vivo this happens. What is the mechanism of this? The mechanism of this is the antiphospholipid antibodies, they target beta 2 glycoprotein. It's a plasma protein that is present on endothelial cells. Now these antibodies, they target the endothelial cells and activate thrombosis. Exactly how this happens, no one knows, but in some way or the other it activates coagulation. Okay. The one of the mechanisms proposed for this is the antibodies. They somehow unmask epitopes on the antigens and somehow they cause thrombosis. So this is basically explanation of the antiphospholipid antibody syndrome, the APA or the antiphospholipid antibody. It binds with the beta-2 glycoprotein, it interferes with the coagulation, it causes platelet activation and aggregation, it causes endothelial cell activation, pro-inflammatory cytokines are released, and there is coagulation. Right? So it's kind of trying to explain how the syndrome happens in vivo. Let's move to the next topic, morphology of the thrombus. So thrombus will be dividing it into various types. Let's see the first two types on the basis of where they are located. If they are located in the artery or in the heart, they are called arterial or cardiac thrombi. Arterial or cardiac thrombi begin at the site of turbulence or at the site of injury. Right? The best example is a thrombus that develops in the coronary artery at the site of atherosclerosis. Right? Atherosclerosis is a type of injury. Therefore, arterial thrombi usually begin at the site of turbulence or at the site of endothelial injury, whereas venous thrombi they occur at the site of stasis. Stasis means where the blood accumulates or becomes static. Best example is deep vein thrombosis in the veins of the leg, the venous thrombi. Let's see the difference between the arterial and venous thrombi. We know arterial thrombi begin at the site of turbulence, venous thrombi occur at the site of stasis. Arterial thrombi grow retrograde, that is towards the heart. If you see coronary thrombus, it grows back from the site of first formation, where it first forms, it grows back. That is, it grows towards the heart. In the same way, venous thrombi, it does grow towards the heart, but the direction here is opposite. That is, it extends in the direction of blood flow. Here it is extending in the opposite direction of the blood flow. Both of them are still going towards the heart. Arterial thrombi are occlusive. We can take the example of myocardial infarction. The coronary artery becomes completely obstructed, occluded. Venous thrombi are also occlusive, but the problem is it's a venous thrombi. The arterial supply is still there, therefore infarction appears late in case of venous thrombi. Arterial thrombi are composed of a meshwork of platelets, heparin and red cells, also regenerating leukocytes. But the most important cause is a ruptured atherosclerotic plaque. So it's primarily caused due to an atherosclerotic plaque on which platelets, fibrin, red cells and leukocytes have become deposited. Venous thrombi on the other hand are basically caused due to stasis, so they contain more of red cells and few platelets. Right? It's usually not due to a atherosclerotic plaque. Most common sites of arterial thrombi are coronary, cerebral and femoral arteries, whereas venous thrombi, as I told you, most common veins of the lower extremities are the most common sites. So this is the arterial thrombus, okay, it's happening on an atherosclerotic plaque. Here this is a venous thrombus, okay, it's not, there's no atherosclerotic plaque, primarily consisting of the red blood cells. Now let's see the difference between antemortem thrombi and postmortem thrombi. Okay, so antemortem thrombi have, if you see under the microscope, they have something called as the lines of Zahn. How are they formed? They are formed because alternate deposition of platelets and fibrin and the RBCs. So you can see over here the RBCs are deposited, then there is platelet fibrin, then there is again RBCs, again platelet fibrin. It creates something called as lines of Zahn. Okay. These thrombi are always attached to the underlying vascular surface. Postmortem thrombi, on the other hand, have what we call as a dependent red blood cell portion. So this is the dependent red blood cell portion. Red blood cells settle down, and on the top they have a yellow chicken fat like appearing surface. This happens due to the blood settling down, red blood cells settle down under gravity, and the remaining cells settle above the RBCs, usually not attached to the underlying vessel wall. Let's talk about neural thrombi. Neural thrombi are those that occur inside the lumen. Best example is in the heart chambers or in the aortic lumen. They happen due to abnormal myocardial contraction, right? When the heart is not able to contract properly, the blood accumulates inside the heart chambers. This is a procoagulant state. Thrombus can happen if the blood is not pumped out of the heart. When can this happen? When the heart is not able to pump, especially in case of arrhythmia, dilated cardiomyopathy, or myocardial infarction of a ventricle. Either it can also happen due to myocarditis or myocardial trauma, or it can happen due to aneurysm, aneurysmal dilatation. So this is the diagram of a mural thrombus. Okay, so you can see a thrombus inside the ventricle. Now, the thrombus are of different types according to the cause, right? Like you can see over here, RHD means rheumatic heart disease. You can see small thrombi along the angle of closure of valves. This is infective endocarditis. This is a very large thrombus located on the upper lower surface of the valves as well as the line of closure. This is non-bacterial thrombotic endocarditis. This is Ligman-Sachs endocarditis. The exact features will be discussed when we come to chapter on heart, but suffices here to say that different type of thrombi are seen in different types of diseases. Lastly, we come to fate of thrombus, right? So once a thrombus has formed, how does it progress? Does it progress? Does it dissolve? What happens to it? So thrombus, as you can see over here, this is resolution. Resolution means complete removal of the thrombus. This happens if we treat the patient on time. Best example is giving a streptokinase or a urokinase drug. It resolves. Propagation of thrombus means the thrombus is becoming larger in size, more and more platelets, more and more coagulative factors are becoming deposited and becoming larger in size. It is offloading the lumen. It is called propagation of thrombus. Small portions of the thrombus can break, it can go downstream, it can block other arteries. It's called thromboembolism. Inside the thrombus, fibrous tissue can be deposited, fibrous blast can start growing. This is called as organization. Also, in an organized thrombus, again a new lumen can be formed. This is called recanalization. So, the fate of thrombus, dissolution, propagation, thromboembolism, organization, or recanalization. Last topic in thrombosis is clinical features. Let's discuss the clinical features of arterial and cardiac thrombi first, then we'll be seeing clinical features of deep vein thrombosis. Arterial thrombi, the most common problem that happens due to thrombosis of an artery is occlusion, right? So it can cause infarctions, also it can cause embolism, and it can obstruct downstream arteries. Venous thrombi, the problem is congestion, right? So distal to the obstruction, there is congestion, edema, and the most important thing, problem is not infarction, but the problem is embolism, right? So the deep vein thrombosis can lead to embolism to the lungs. Next topic is disseminated intravascular coagulation. This is a very important topic. It is seen in many ICU patients. It is one of the most common causes of mortality and morbidity. As such, is not a single disorder. It's not a single disease. It is a disorder associated with many diseases. Most of the diseases in the end, when very acute, culminate in disseminated intravascular coagulation. Okay, so as I told you, disseminated intravascular coagulation is associated with multiple things, multiple clinical scenarios ranging from obstetric complications to advanced malignancy to sepsis, all can cause DIC. Now, the problem with DIC is it leads to widespread formation of thrombi in microcirculation, right? So, in microcirculation means arterioles, capillaries, all these places there is widespread formation of thrombus. These thrombi, what do they do? They cause circulatory insufficiency and organ dysfunction, right? Particularly of the organs very susceptible to hypoxia, like the brain, lungs, heart, and the kidneys. It causes organ dysfunction. On the top of that, what happens is because of widespread thrombosis, all the platelets and coagulation factors are used up. So when the platelets and coagulation factors are used up, initial symptoms of thrombosis, it can evolve into a bleeding catastrophe. Right? So because whenever all the clotting factors and the platelets are used up, no more platelets and clotting factors are required wherever it is essential. It leads to a bleeding catastrophe. It leads to a hemorrhagic stroke or a hypovolemic shock. So this is a dual thrombotic and a hemorrhagic state. Therefore, it's very dangerous. How this happens, I'll try to explain with the help of this table. There is some precipitating event, there is activation of the extrinsic pathway, it leads to the coagulation cascade, excess thrombin is formed, excess thrombin leads to excess clotting, leads to ischemia, impaired organ perfusion and end organ damage. At the end, there is activation of plasminogen to plasmin, excess fibrinolysis and all the platelets and the clotting factors are used up. It leads to excess bleeding, which causes shock or hypotension or impaired vascular permeability, impaired vascular perfusion. This is what happens in DIC. Next topic after DIC is embolism. We'll be seeing the definition, we'll seeing the types of embolism, right? Types include pulmonary embolism, systemic embolism, fat and marrow embolism, air embolism, and amniotic fluid embolism. We'll be discussing each of them. Let's start with the definition of embolism. So what does embolism mean? Emboli is a detached intravascular solid, liquid or gaseous mass. So till now our concept was that it's a solid mass, but it can be a liquid or a gaseous mass also. It is intravascular. The embolus is carried by blood from its point of origin to a distant site. So if we take the example of deep vein thrombosis, the embolus is carried from the veins in the legs to the coronary arteries. What does it do at the point where it lodges? It causes tissue dysfunction or it causes infarction. So what are the types of emboli? Let's start with the first one, which is pulmonary embolism. Pulmonary, as the name suggests, is embolus lodging in the lung, or rather the lung vessels. The emboli chiefly originate from deep vein thrombosis. They are carried through larger veins and lodge, or first they enter the right side of the heart. From the right side of the heart, they go to the lungs in the pulmonary vasculature. What do the emboli do to the lung? It can lodge in the male pulmonary artery, or it can straddle the pulmonary artery bifurcation, as we can see over here in this diagram. The embolus is lodging at the bifurcation of the main pulmonary artery. It's called as a saddle embolus. Or it can pass out into smaller branches also. Most of the pulmonary emboli are clinically silent. They do not produce symptoms. However, what it can do, it can produce sudden death because of right heart failure, which is called as cor pulmonale, or it can cause cardiovascular collapse when the embolus obstructs more than 60% of the pulmonary circulation, right? It can cause right heart failure or cor pulmonale. Systemic thromboembolism. Systemic emboli are all those emboli other than the pulmonary embolus. It arises mainly from intracardiac mural thrombi. So inside the heart chambers. When a thrombus develops, it can embolize and go to different parts of the body. They are called as systemic emboli. They can travel to a wide variety of sites wherever the embolus lodges, right? The symptoms that arise will be according to the tissue where the embolus is lodging. Most of these emboli from the heart come to rest in the lower extremities or in the brain. Next, we'll go to fat and marrow embolism. Fat and marrow embolism can be seen after fractures of long bones. The marrow elements can enter the circulation, or it can happen after a soft tissue trauma or after burns. What we see microscopic fat globules chiefly in the pulmonary vasculature, right? So this fat or marrow, it enters the circulation and gets lodged in the pulmonary vasculature. Most of the cases are asymptomatic. We call it as fat embolism syndrome when it is symptomatic. What happens in fat embolism syndrome? As I told you, the fat globules are found in the pulmonary vasculature. Therefore, it is characterized by pulmonary insufficiency mainly. If it goes to the brain, neurologic symptoms, anemia can be caused because RBCs can be trapped in the fat emboli and can cause thrombocytopenia as well. Air embolism. Air can be introduced in circulation during either obstetric or laparoscopic procedures, or it can happen as a consequence of chest wall injury. What happens is these gas bubbles within circulation can coalesce and form frothy large masses. These large masses can obstruct vascular flow, and wherever it is obstructing the vascular flow, distally there will be a ischemic injury. Important point is a larger volume of air is generally required, more than around 100 cc to produce a clinical effect. Smaller volumes of air are regularly introduced during any intravenous access, and usually it does not cause embolism syndromes. Let us understand the concept of decompression sickness. Now, this is a term that is usually applied to sickness that happens in divers when they do deep sea diving. Also, it's called as caisson sickness or divers disease, also called as bends. What happens is chiefly there's a buildup of nitrogen bubbles in the bloodstream. Okay, so how does this happen? What happens is as the diver descends, you know that the pressure increases. Now, when the pressure increases, the nitrogen that is there in the blood, it is absorbed in the body tissues. Now, all this nitrogen that is absorbed in the body tissues, it has to come back into the circulation and then into the lungs, and it has to be thrown out, right? Now, what happens is when the diver is ascending slowly, the pressure will decrease, as a result of which slowly the nitrogen will come into the circulation and slowly it will be eliminated by the lungs. But if the diver ascends very fast, all of a sudden all the nitrogen will come into the circulation, right? And it will become a bubble in tissue and in the bloodstream. Now, because of this excess buildup of nitrogen in the circulation in the bloodstream, it will create a sickness that is called as caisson sickness or diver's disease. What are the symptoms? Symptoms are unusual fatigue, skin itch, pain in the joints, right? Pain in the joints and muscles. That is why it is also called as the bends. It leads to dizziness, vertigo, numbness, and shortness of breath. So it's very important that once deep sea diving has been performed, the ascent should be very slow. What is the treatment? Treatment is in a high pressure hyperbaric chamber where the pressure is high. Chamber is built such that the pressure on the outside is high and slowly the pressure is brought back to normal, and the patient also receives 100% oxygen. So this is how it happens when the diver descends down into the depths. There is compression. The outside pressure is quite high. Therefore, the bubbles are going down in size. They are going into the tissues. When the diver ascends, if ascends very fast, such large bubbles are formed. Frothy masses are formed in the circulation, which gives rise to this disease. Next is amniotic fluid embolism. Amniotic fluid embolism is a complication of labor and also seen in the immediate postpartum period. Underlying cause, as you can guess, is infusion of amniotic fluid and fetal tissue into the maternal circulation. This may happen because of a tear in the placental membrane or rupture of the uterine veins. Let's move on to the topic of infarction. We'll be seeing infarction under these headers. Let's see the definition of infarction first. So infarction is basically an area of ischemic necrosis. The cause of ischemic necrosis is occlusion of an arterial supply or of venous drainage. So either the arterial supply to a particular tissue or area of a tissue or area of an organ is lost, as a result of which the tissue distal to the block, it undergoes ischemia and ischemic necrosis. Examples are myocardial infarction following atherosclerosis of coronary arteries, cerebral infarction following embolism from the deep vein thrombosis, pulmonary infarction following embolism from deep vein thrombosis, bowel infarction again can happen because of deep vein thrombosis, ischemic necrosis of the extremities like gangrene in diabetics. This is also an example of infarction. What are the causes of infarction? Causes include, as I told you already, it can be either an arterial obstruction or a venous obstruction. Arterial obstruction can be thrombosis or embolism, atherosclerosis, local vasospasm like Raynaud's phenomena, you must have studied this phenomena, hemorrhage into an atheromatous plaque, extrinsic vessel compression like tumor compressing a vessel or arteries compressed by a tumor. Again, you can imagine that the distal portion must be undergoing infarction. Torsion of a vessel like intesticular torsion or volvulus, traumatic vascular rupture, vascular compromise by edema like the anterior compartment syndrome, entrapment of a vessel or entrapment of a bowel in an hernial sac. It can lead to infarction because of compression of the arterial supply. Venous venous thrombosis can cause infarction, but more commonly when the venous obstruction is there, it leads to congestion. Infarcts caused by venous thrombosis are usually seen in organs with a single efferent vein, like the testis and the ovary. What are the types of infarction? So we divide infarcts into various types. First division is in red and white infarcts. White infarcts are seen in solid organs with end arterial circulation. That means these are the tissues or these are the organs which receive blood supply through a single artery. And the development of collaterals is very less. Okay. Uh, the best example is heart, spleen, and kidney. They are end arterial circulation organs. We can see over here, this is a white infarct. What is a red infarct? A red infarct is seen in tissues with venous occlusions, alright? Because the arterial supply is still there, the RBCs are still there, the infarct develops a red color. Example is testicular torsion. In lung, there is a red infarct. What happens is because there is loose and spongy tissue in the lung, blood can collect in the infarcted zone, as you can see over here. It's seen in tissues with dual circulations, right? White infarcts were seen in tissues with end arterial circulation. Red infarct is seen in tissues with dual circulation, like the lungs and the small intestine. Here, the collaterals can develop, blood can flow from an unobstructed parallel supply. In tissues previously congested with sluggish venous flow is sluggish again, red infarcts. Also, when flow is re-established to the site of previous arterial occlusion, for example, we can give this is basically happens after therapy, like there is an obstruction of the coronary artery, the distal area undergoes white infarct. When you re-establish the flow, the blood starts flowing to the necrotic area and then it appears red in color. So, red infarct can happen at the site of previous arterial occlusion after angioplasty. Morphology of infarction. Grossly, an infarct, we are here mainly describing an arterial infarct or a white infarct. It is wedge shape, as you can see. This is a kidney. Kidney, receives blood supply from the renal artery and which divides into various branches. Okay, so but this particular branch supplying this particular area of the kidney must have got obstructed. It is a wedge shaped infarct. The occluded vessel, it usually enters the kidney from the apex, right? So this we can consider an inverted triangle where the arterial supply is at the apex and the periphery of the organ forms the base of the infarct. If the infarct extends up to the serosa, you can get a fibrinous exudate on the serosal membrane. Microscopically, it is ischemic coagulative necrosis. Okay, so the microscopy of an infarcted area will be nothing but the coagulative necrosis. What are the factors that influence infarct development? So infarct development, how much infarction will happen, how much it will last, whether it will be a red or a white infarct, it will all depend upon certain factors. These factors are anatomy of the vascular supply, the rate of occlusion, whether it is happening suddenly or slowly, tissue vulnerability to hypoxia, that is certain tissues develop infarction quickly and certain tissues develop slowly. Hypoxemia is again another factor. Let's see each of them in detail. Anatomy of the vascular supply, what this means is if there is an alternative blood supply available, then the infarction will be delayed. Like the lungs and the liver have dual blood supply, this protects against infarction. In contrast to this, we saw the kidney and the spleen, they are end arterial and therefore sudden obstruction can lead to tissue death. Rate of occlusion. Slowly developing occlusions are less likely to cause infarction. Why? Because there is time for development of collaterals. Which are the tissues vulnerable to hypoxia? Neurons are the most vulnerable to hypoxia. Within 3 to 4 minutes of hypoxia, they undergo irreversible damage. Myocardial cells again are very much vulnerable, but they have at least 20 to 30 minutes before they die. In contrast, fibroblasts in the myocardium, right, they can remain viable after many hours of ischemia. Hypoxemia, if the blood content of oxygen is low, it increases the likelihood of infarction. So these are the factors influencing infarct development. Next is the topic of shock. We'll be seeing shock under these headers. So what is shock? So shock is a state in which the tissue perfusion is impaired. This leads to cellular hypoxia, right? So the perfusion of the tissues, each and every tissue is impaired, as a result of which each and every cell receives less amount of oxygen than is required. Now why this can happen? This can happen because of reduced cardiac output when the heart itself is not beating properly, or it can happen due to reduced effective circulating blood volume. What does this mean? There is some volume of blood that is circulating, but most of it during shocks syndromes have gone into the extravascular compartment, as a result of which there is fluid in the body, but the fluid that is circulating in the body is less, right? So that is reduced effective circulating blood volume. So when tissue perfusion is reduced due to either decreased cardiac output or reduced effective circulating blood volume, it leads to a condition that is called as shock. What are the types of shock? Shock we can divide into three major types. First is cardiogenic, as we said in the definition. The heart is not beating properly, there is decreased cardiac output, and this is leading to a shock state which is called as cardiogenic shock. Okay, this can happen due to various causes affecting the heart: myocardial infarction, ventricular rupture, arrhythmia, cardiac tamponade, or pulmonary embolism. All this lead to failure of myocardial pump. Second is hypovolemic shock is the second cause, reduced effective circulating blood volume. This happens due to fluid loss, hemorrhage, vomiting, diarrhea, burns or trauma. Third one, shock associated with systemic inflammation. What is happening over here? There is activation of cytokine cascades, peripheral vasodilatation, pooling of blood. It can lead to disseminated intravascular coagulation. All this causes reduced effective circulating blood volume. Right? This can happen due to microbial infections, superantigens as in toxic shock syndrome, in trauma, burns, pancreatitis, etc. These are three major types of shock: cardiogenic, hypovolemic, and shock associated with systemic inflammation. Two other types of shock: neurogenic and anaphylactic shock. Neurogenic shock is seen in setting of an anesthetic accident or a spinal cord injury. So spinal cord injury leading to shock is called neurogenic shock. Anaphylactic shock is associated with hypersensitivity reaction, IgE mediated hypersensitivity reaction. If you remember, this is type 1 hypersensitivity reaction. In both of these conditions, neurogenic and anaphylactic shock, there is vasodilatation. So vasodilatation leads to hypotension and tissue hypoperfusion. What is the pathogenesis of shock? We are talking about the shock associated with systemic inflammation, also called as septic shock. Point to be noted is shock. It ranks first among the causes of death in intensive care units. Intensive care unit patients are usually having, out of the various conditions, most of them have a bacterial infection, a widespread bacterial infection. This causes shock, which is called as septic shock. Mortality rate exceeds 20% in intensive care units. The incidence is rising, ironically. Now you know that there are better antibiotics available, but still the incidence is rising. Why? Because there are improvements in life support for critically ill patients. So more number of critically ill patients are coming to the ICU. There are growing ranks of immunocompromised hosts, and this is very important because of chemotherapy, HIV, advanced stage, immunosuppression. All this is creating a subset of patients who are coming to the ICU requiring life support. There is increasing prevalence of multi-drug resistant organisms. As you know, the resistance to drugs is increasing. So all these three reasons, it is leading to increased incidence of septic shock. It is frequently triggered by gram-positive bacterial infections, followed by gram-negative bacteria and fungi, and most commonly by gram-positive bacterial infections. So in septic shock, the pathology starts because of these microbial products. These microbial products activate the complement system. This complement system acts on the endothelium. Microbial products also activate the neutrophil and monocytes, which release TNF, IL-1, and other factors which activate the endothelium. The neutrophil and monocytes also release certain cytokines. Okay, the microbial products also activate factor 12. This factor 12 is a procoagulant factor. Endothelium also, as you know, has a procoagulant effect. It has an antifibrinolytic effect. This leads to formation of microvascular thrombi, that is formation of thrombi in various organs, which is also called DIC. It leads to tissue ischemia and finally leads to multi-organ failure, also leads to adrenal insufficiency. Endothelium and the cytokines released by neutrophils, they include interleukins, nitric oxide, platelet activating factor, etc. All these cause vasodilatation and increased vascular permeability. The fluid goes out of the vessels. It leads to decreased perfusion and multi-organ failure. Other cytokines like IL-10, okay, what do? They cause immunosuppression. They also cause systemic effects like fever, diminished myocardial contractility. All these come together to cause multi-organ failure, that is called as shock. What are the clinical features of shock? Shock begins as an initial non-progressive phase, right? So initially, when the tissue perfusion is going down because of either diminished myocardial contractility or due to diminished effective circulating blood volume, there are various reflex mechanisms that are activated which try to maintain perfusion of vital organs like constriction of blood vessels, etc. Initially, the perfusion is maintained. It is called as a non-progressive phase. Next phase is called as a progressive stage. Here what happens is slowly the tissue perfusion is going down. This is slowly worsening circulatory and metabolic imbalances are happening. This can lead to lactic acidosis. And last stage is what we call as an irreversible stage. Here the cellular and tissue injury is very severe, right? That even if you try to correct the hemodynamic defects, survival is not possible. So shock progresses to three stages: a non-progressive stage, progressive stage, and an irreversible stage. In these two stages, we can try to salvage the patient. Here, it's not possible to salvage the patient. So morphology of shock, that is what changes do the organs show in case of shock. So essentially, as we all know, shock will lead to an hypoxic injury to the tissue. So the changes that would be seen would be essentially those of hypoxic injury. Like adrenal gland will show cortical cell lipid depletion, kidneys show acute tubular necrosis, lungs show diffuse alveolar damage, brain, heart, lungs, kidney, adrenal glands, and the gastrointestinal tract. All these organs will also show disseminated intravascular coagulation. That is, there are fibrin-rich microthrombi that are seen in vessels of these organs. Petechial hemorrhages can be seen on serosal surfaces and the skin. This is because in case of DIC, which happens after shock, there is consumption of platelets and coagulation factors, so small petechial hemorrhages are seen. Clinical features of shock. So the patient in shock will present with hypotension. If you check the pulse, it will be a weak, rapid pulse. Patient will be breathing fast, that is tachypnoea, and the skin will be cool and clammy. Also, cyanosis will be seen. However, rapidly what happens is the shock will change into cardiac, cerebral, and pulmonary dysfunction, that is, multi organ failure happens, and eventually there are electrolyte disturbances, metabolic acidosis, all that, and eventually what happens is patient lands into multi organ failure. With this, we come to the end of this lecture. Let us see some questions. You can go through the answers. I'll discuss the answers in the next lecture. First question is, what is Virchow's triad? State the factors influencing infarct development. What is the mechanism of decompression sickness? Alright, so you can go through the answers. They are there in this lecture. We'll be discussing it next time. Thank you very much for tuning in to Pathology Basics. Hope you enjoyed this lecture. Please, if you did like this lecture, subscribe to it and share it with your friends. Thanks a lot.